Welcome back, everybody. We are in our 33rd episode, and we are talking about a very popular knee injury and controversial one these days, the ACL. With more than 100,000 occurrences every year, the ACL tear is one of the most common knee injuries we see in physical therapy. I'm Dr. Janae Brown, and I am joined by my favorite three physical therapists and colleagues.
Dr. Bay.
Dr. Daisuke.
Dr. Sandoval.
So, guys, let's get into it. Dr. Bay wrote this blog. She chose the ACL, maybe stole it, some would say, but chose it. Dr. Bay, why did you want to talk about the ACL? Why did you pick the ACL for your knee injury to discuss?
Well, Dr. Brown, it really interests me right now. I have several cases on my patient caseload right now that are different stages of ACL injury, and it's a big challenge to ACL rehab properly, so I thought diving deep into the topic could only improve my ability to help my patients.
Very good. Very good. Okay, so we're going to start with anatomy, and I'm doing anatomy today, so let's just cross our fingers.
Oh, God.
Where's my cross? And hope that I get this right. So the ACL is one of four major ligaments in the knee. It's the most common to be injured. And it's a rope-like structure that travels from, and I'm going to show you guys from the back here. So it's coming from the femur, the lateral condyle of the femur, and then it travels to the front, and it's behind here, and it's going into the intercondyloid surface of the tibia. They're all waiting for me to fail. Okay. It resists anterior shear of the tibia, so keeping the tibia from moving forward on the femur, and rotational forces at the knee. And it's most tensioned when the knee is about 30 to 90 degrees flexed. It is a cruciate ligament, which means that it crosses. Give me my cross back, okay. Dr. D. There we go. It crosses. And it crosses with the PCL, which is the posterior cruciate ligament. And I think that I got everything in about anatomy, unless I missed anything, Dr. Bay.
I'm very happy with that.
Are you happy with that? Cool. Okay, so that's anatomy. We're going to move on from anatomy to mechanism of injury, and Dr. D is going to be taking that. Talk to us about how people get injured, typically with an ACL injury.
So mechanism of injury-wise, there's two broad, obviously, injuries as far as contact and non-contact. Majority of them are going to be non-contact injuries. There's different types as far as the mechanism itself. So sometimes you can land from a jump, twist the knee rotates inward. That can cause the injury. Sometimes it could be more from cutting or changing directions. And it's usually followed up by a popping sensation, or you can actually hear the pop. What's the word? Auditorily.
Auditory?
Audible pop.
I had a pop in my calf.
And then you'll have some swelling, instability in the knee, pain with weight bearing, or just pain in general as well. And 50% of the time when it comes to these ACL injuries, it's in combination with some cartilage injury or a meniscus injury, and other ligaments also can be involved as well. And that also complicates some of the rehab process and the surgical process as well. Mm-hmm. And as far as classifications go, just 3 grades. First grade is going to be the mild one. It's a very small injury or loosening of the ligament itself, and you can still have some of the stability of the knee. So sometimes you might not actually have to have some type of surgery afterwards. Grade 2, you'll have a partial tear, starts to compromise the integrity of the knee joint itself, and then grade 3 is obviously the full tear.
Full on tear.
Yep.
Yeah. Do you guys has anybody here had an ACL tear come to them without straight on, like someone came in and said their knee hurts, and then you were able to clinically diagnose that there was ACL tear? Yeah. Yep. Doctor, have you, Dr. Bay, had anybody come to you like that? that
Not
you didn't
ones
know?
that you haven't seen first.
Not ones that I haven't seen first. What about you, Dr. Sandoval? Have you seen anybody like that yet?
It hasn't been confirmed yet
Yeah.
because an MRI hasn't been done.
Okay.
But I am suspecting that one of my patients also has an ACL tear.
Got it. Do you feel like, Dr. D, the patients that have come to you that you've had to like clinically diagnose, that those are the things that have happened? They told you they heard an audible pop, or did you feel like you knew from your testing, your clinical testing, that like did the mechanism of injury follow kind of what the research shows, or did you kind of see it a little different?
No, it was pretty
It's
consistent.
pretty consistent?
Yeah. Basically, all the symptoms that we just talked about and the signs were there. And then the Lockman test basically confirmed it. So, yeah.
And were a lot of them non-contact injuries, or were they contact injuries?
All of them were non-contact.
All of them are non-contact. Interesting. Yeah, most of mine that I've had have been non-contact injury. Well, I've had a couple contact, but I've had also, I guess, a little bit of both. But what's funny for me is when they come to you really fresh, it looks almost like an LCL injury, like the lateral pain. They complain of, the thing that I think gets us is like that they can't extend their knee, all the way. But yeah, it's very interesting. It could be when it's acute, you don't feel a lot of obviously laxity because there's a lot of swelling in there, right? So I was just interested to see if you guys had seen like a consistent MOI, because sometimes our research tells us one thing and then we clinically see something different. So yeah, cool. Okay, well, thank you for covering mechanism of injury. Dr. Sandoval,
Yes.
talk to us about what treatment might look like.
Yeah, so when determining a treatment plan, there are a couple of factors to consider. One of the factors is the grade of the ACL tear, the goals of the patient, and activity levels, right? Are they physically active, before the injury? Are they trying to become or, regain that same level of physical activity after the injury? If they are a competitive athlete, they are looking at a surgery more than likely to, regain that level of competitiveness. If you're a patient and you are, deciding whether or not you actually want that reconstruction surgery, there are a couple of things to consider. One is that the ACL actually has very poor blood supply to it, so its ability to heal itself is limited. So if you are choosing a more conservative approach, that is, one thing to consider. And you'll also likely have a less stable knee because that ligament provides for stability, right? So you are predisposing yourself to some future injuries if you choose a more conservative approach, which, is their choice, but that is something to consider. So when it comes to having that reconstruction done, the ligament itself, the injured one, gets removed, and then it gets replaced with a tendon or a ligament that either comes from that patient's own body or it comes from a donor. And then, they come to us and they start the rehab process.
Awesome. So, Dr. D, do you agree that conservative rehab doesn't always work if it's a full tear or full rupture?
No, not necessarily, because I've actually treated some fully torn ACL patients that had active goals, and we were able to get them back to playing basketball and running and stuff. So it just it's all individualized. It really depends on the patient, because, when they first come to you and they're just having just so much limitations in their range of motion and strength, and no matter what we've been working on, it's just not progressing. Sometimes surgery is the only approach that we can possibly take, and it is what it is at that point. But some patients will come in and they have full range of motion and full strength, and they have a fully torn ACL. So it just really depends on the person.
Yeah. I think too, probably based on what we're seeing when we're looking up this information right now, I still think that surgical repairs are outweighing what we're seeing in the research being done, right? But conservatively, we're seeing a lot of new research come through saying, okay, this doesn't have to be the choice. We're actually seeing people who aren't actually having surgery have good success. But I think they also been playing a lot with the surgical procedure itself, because, right, most of the research shows that it's 50% sort of effective, which is not a great option still, surgery. So, so with that surgery, have you guys seen that certain type of surgical options do better, allograft versus autograph patellar tendon versus hamstring. Have you guys seen anything that you feel does better in your time with ACLs, or just kind of seen it kind of just really depends more on the rehab and the surgeon, or either or? Anybody have any thoughts? You have any thoughts, Dr. Bay? No?
In my experience, just the trends I see for me personally, I think it has to do more with the athlete's condition prior to the injury, and maybe certain body type factors that might predispose them to more laxity, might make it more challenging, especially when they've harvested some of their own materials from their body, making them a little bit more prone to tendinopathy later. But
Dr. D, you have any thoughts? No? Bring this closer to you.
I feel like generally, I think for me, I like hamstring grafts a little bit more, mainly because it reduces some of the, early onset of patellar tendon discomfort and stuff like that. So that's just my preference more than anything else. But yeah, just from experience.
I've seen both, and I haven't seen, I think the rehab, to me, the rehab is the factor that I've seen. Again, it's hard because we don't always see, we see our patients for 12 months. Sometimes we don't see like them 2 years or 3 years. We don't always know what happens down the line, longevity wise with that. But re-tear wise, I haven't seen a huge difference myself with hamstring versus patellar tendon. Yeah. Okay, cool. All right, we're going to move into the phases of rehabilitation and rehabilitation in general. And Dr. Bay is going to take us through the pre-op plus 5 phases of rehab. And we'll chat through a little bit about some things that we do and we see as we kind of talk about this. So Dr. Bay, tell us what does rehab look like in terms of the phases, and give us a little insight.
yeah, so whether or not you choose to take a conservative or non-conservative approach, a lot of the same things are going to be considered. But if you are having surgery, there is a time that you spend before surgery, the pre-op phase, and then after surgery, it's your recovery from surgery, a time period spent for strength and neuromuscular control. Then you get moving a bit more, running, agility, and landings, return to sport, and then arguably the most important is prevention of re-injury is the last phase. So I want to discuss a little bit about what we look for in each phase. So before surgery, your goals are really to keep swelling down, restore your flexibility again, and see if you can get your quad and hamstring as much as 90% of the strength restored equal to the opposite limb. After surgery, our first big goal is trying to get the knee straight again, get our quadriceps muscle firing well, and again, keeping the swelling down. In our next phase, we work on restoring the patient's ability to balance well, get a lot of their just kind of single joint muscle strength and compound movement strength back, as well as working on a big item, which is the single leg squat. That's going to really dictate their ability to prevent re-injury in the future. A lot of that landing and change of direction control happens in our single leg squat position. And then we move on to mastering all types of plyometrics, making sure we are very agile, completing an agility program. At this next phase, we should be able to attain full strength, and the patient can even start to dabble in their sports and modified gameplay drills. The next phase is that return to sport phase. So this is where the programming gets very individualized based on the athlete and their goals. They should be participating in regular drills for whatever that sport may be that they would do when they weren't injured. Always continued strength training, but really importantly, they should be mentally strong and feel confident in their leg at this point. And it would be unsafe for them to progress too much farther if they don't have that confidence. I don't play soccer, but my current patients are soccer players that are going through their ACL injuries, and talking to one of our aides, Jill, who's helping coach them, she says that if you go in and you don't go in full force, which you might do if you're not confident, it might leave you exposed to injure yourself. So really making sure each player is ready to take on committing back to their sport and all the stresses of that. So they, at this point, they're beginning to transition back into sport, and then that sets us up for the last phase, which is a commitment for the rest of your life to try to not get injured again. So that means always practicing your plyometrics, your balance, your strength, making sure that every time you train or participate in your sport, you're warming up properly. And then there are programs out there that help consolidate this information out there. There's several different ACL injury prevention programs, and they kind of compile a lot of great exercises and drills that could be participated in regularly, all to try to keep the body kind of optimized so that you can take the forces of, quick stops, starts, changes of direction, landings, accept them well through that knee. And that's
Awesome.
it. All of that just for an ACL.
Lots of stuff. So I think the controversy with ACL right now is time, right? We're transitioning from being sort of telling our patients that it's only going to take 6 months. I think when these surgeries started being done, it was like 6 months was that number, and then we started to see that when we were sending them back at 6 months, even when their return to sport tests were passed, they were re-tearing, right? So we've done a lot more research, and the research right now shows 9 months. Would you guys are you using time as a base for criteria to return back to sport? Meaning if your patient hit 8 months and they passed all your return to sport tests, and psychologically they passed, the psych tests that we do have that, I can't remember the name of it off the top of my head, right? Do you remember the name of the test they take? So there is a psychological portion to make sure that.
RSI?
No,
Oh, yeah,
RSI.
RSI. Yeah, sorry. Thank you. The RSI. But say they pass all that, would you send your athlete back at 8 months if they passed, Dr. Bay? Would you have a couple? You have some right now, so
I haven't had any beat the timeline yet,
Okay.
so I can't speak. I haven't had to make that decision yet.
Okay. Dr. D?
I think it depends on the sport and the time of the season and how important that player is.
Okay.
Yeah.
Good
I
question.
think that'll determine if they should return or not. Yeah.
What do you think when we hear 6 months or 8 months or 7 or just a time, like when I hear something that is sooner than I think, I always think that, like, for example, we've circled back and talked about this, but a professional athlete who is being told 6 months or 8 months or whatever is different from our high school, our college athletes being told that, right? Because this is not their life. So they're not in rehab every day, right? They're not strength training on the days they're not doing PT. They're not agility training and plyometric training, and they're not doing speed and endurance training. Like, they're not doing that every day, right?
Or people assisting their recovery.
Every day. Like, this is, yeah, exactly. So I think that's hard when we get people who are told a time frame, because it really does depend on the athlete. And I think time is a good measure to say, okay, we were not seeing that, like, before 9 months people are being successful. I think that that's fair for us to use it like as a minimum. But yeah, it's hard to, when they're told that they're going to be back in 6 months, and you have to be like, well, actually, that's probably not likely. Yeah. So time as a measure. What about return to sport testing? Does everybody do clinical testing? Or does everybody like to do sort of the 3D sports analysis testing? You guys have any thoughts on that?
I think the more testing you do, the better,
Yeah.
right?
For
The
sure.
more information you have, the
Yeah.
better decisions you can make, right? And the safer you'll be, right? And at the end of the day, we want to make sure that they are safe whenever they return to sport. So
Yeah.
I will try to do as much as I can.
Yeah. Thoughts? No?
I
Same thing?
agree. Yep.
Yeah. Same. Yeah. We've been using the Melbourne protocol here, which is, I think, by far like the best one I've seen out there right now. Just because it does, like, it's really inclusive. It's time-based. It's clinical testing. They recommend doing 3D sports analysis, and then there's the RSI in there as well. I just feel like you just have to be, it's like everything has to go well. And we're not even talking about the non-surgical limb, but that limb is often problematic, right, Dr. Bay? Like you have a patient right now that has,
Yeah. I've actually switched the emphasis, and I'm limiting her phase progression based on the non-surgical limb because her doctor even told her that he was surprised that limb didn't tear first.
Yeah.
So, to get her ready, I've backed up and I am working on the other side, and then we will progress forward.
Yeah. What are your guys', as I'm going to end on this one, thoughts on just people being, so I guess I'd phrase this like, there are some people who just tear their ACLs more than others.
Mm-hmm.
Would you guys say that you could classify that, like that you have an idea of who is at risk? Like who are our risk factor patients that we see tearing our ACLs, and what can be done, do you guys think, to keep, if anything, right? Because that's the question. Can anything be done to prevent those athletes from being at risk? Thoughts? Yeah.
I want to reach for some very low-hanging fruit here.
Okay.
I think if you have already torn an ACL, you're at risk of either re-tearing or tearing the other side.
Yeah. So what would you tell an athlete that tore their ACL? Would you say, you shouldn't return back to sport because you're likely to tear your other ACL? Or would you say there are some things...
I don't think I would say that.
Okay.
Mm-hmm.
Okay. Or would you say there are some things that we really need to work on if you want to go back to sport and not tear your ACL again?
I would say the latter. And it really just depends on the patient. There are many different factors that could, cause them to go down this path of potentially re-tearing or tearing something else. For example, Dr. Bay's patient, I know it's more closely related to their ankle/foot, and that's the reason why she's holding off on, progressing that patient.
Yeah.
I have someone right now who I'm working more so on their hips and their hip control and hip stability.
Yeah.
So there are many different reasons, many different things that you could tackle. And it's just, I think, individualized to that specific person.
Yeah. Perfect.
Yeah.
Awesome. Well, thank you all for joining us today. We hope that you guys learned something new. If you are interested in working with us, you should know that we treat clients on site, but also virtually. And you can subscribe to our email list at physicaltherapysanpedro.com or follow us on Instagram, YouTube, Facebook, and look us up on Google and Yelp. Check out all our awesome reviews. We have an awesome team here. We would love to help you, and we'd love to answer any questions you have. So drop a question below or DM us if you have a question. And we will see you guys next time. Bye.